My name is Dr. Paul Coffin. Today we're going to talk about orthotics. I make orthotics that are non-compressible so that they provide arch support through the arch with the arch lined up appropriately, but they're still able to allow the joints in the foot to move back and forth like they naturally would, but only staying within their mid-ranges of motions and not coming out of place and subluxing. If we're going to really understand orthotics and what we need to do with orthotics, we have to understand a little bit about foot biomechanics. The patient has an ankle, which basically is a hinge joint that goes up and down, and underneath that ankle joint is a subtalar joint that goes back and forth. And when the subtalar joint goes back and forth, it actually rotates this to the inside, and since the tibia and the fibula are hooked onto it, it internally rotates the knee as the foot pronates. Now, a couple other things that happen as it pronates. When the foot rotates to the inside, it takes all these little joints in here and it loosens them up. They're all triangular in shape, and as they get loosened up, it makes the front of the foot very wobbly. And as the joint gets wobbly here, it lengthens out the bottom of the foot, stretching out the plantar fascia and the flexor hallucis longus tendon, which then pulls the big toe down and pulls the first metatarsal up, and creates a jamming when the person tries to walk off of this. Now, the foot actually is connected to the tibia and fibula, and that tibia and fibula go up to the knee. So when the subtalar joint pronates, it also internally rotates the knee. And the knee is basically a hinge, and it needs to be perpendicular to the direction we're going. And so what we'll do is we'll externally rotate at the hip and straighten out the knee. So the whole goal of the orthotic is to line everything up along the longitudinal arch, taking the pressure off the flexor tendons and as well as the plantar fascia, so that the big toe joint can glide up over the top of the first metatarsal. But we don't want to stop all the motion like some orthotics do, hard orthotics, and we want this to still be able to rotate back and forth. We just don't want it to be going too far. And we need to keep those hinges lined up, and if an orthotic doesn't do that, it won't work any better than the door will work if the hinges are out of alignment. We can see people walking with their foot pointed out toe, and we can see that the big toe joint is not aligned with the knee at all if we go to look at people walking at the mall. Now, the real problem with that comes is really at the hip. If we take a look at the hip joint, if the hip is in its neutral position, the knee is going straight ahead, and when the knee goes straight ahead, it can move back and forth while you're walking. But if it's turned to one side or the other, then it doesn't work very well. So what our body will do is contract the muscles to keep that knee going straight ahead, and many times that means that the foot's pointed out. And when it points out, then the big toe joint can't bend. So what we need to do is line everything up so the hinge at the knee and the ankle and the big toe joint. Because if it doesn't, it will actually end up externally rotating the hip, and when that happens, the hip will tilt forward. So if the knee gets internally rotated because of an excessive pronation, then what you're going to do is take your hip joint and you're going to rotate the hip out until the knee is straight ahead again. But remember that tibia and fibula are hooked on, and it's going to end up pointing the toe out, and we can see people walking that way. Now, going back to the hip for a second, when we rotate the hip out of its socket, the pelvis starts to tilt forward, causing problems with the back getting lordosis, or a curve in the low back, and it takes and eliminates the ability of the sacroiliac joint to move. If we take and line up the foot, it'll actually take and turn the knee back to where it belongs straight ahead, and the hip will be able to line back up, allowing the pelvis to tilt backwards and helping low back problems. If we take and we line that foot up so the arch is back in its neutral position with all the joints in the foot in their mid-range of motion and not rotating back and forth.